Yes, sir.
Introduction will start.
Yes, sir. Please start, sir.
Good evening to one and all. Yes. Keri,
Yes,
madam.
joining us. Please start, sir.
Good evening to one and all. I think we want today topic renal nutrition. Renal nutrition for the peoples with the diabetics, the intersection to evidence and guidelines and clinically practice. Is speak by Meenakshi, Mrs. Meenakshi. The introduction of Meenakshi, the registered dietitian with 27 years, the experience in the clinical and therapeutic nutrition. He is a certified bariatric and a critical nutritionist, certified diabetic educator, and a nutrigenomic consultant. He is a certified LLC certificate for the renal and onco nutrition to the European Society of the Clinical and Nutrition and Metabolism. She is a state rank holder, best outcoming student. The nutrition, he is also a National Executive Committee member, Indian Dietetic Association. He is a former president of the Indian Dietetic Association Chennai chapter. He is a resource person, the several national and international conference of the nutrition and diabetic renal, enteral and parental nutrition. The organizing the several national and international continued nutrition education program and workshops. He is the author of the Diet Metric, the Handbook of the Food Exchange System 2019. He is authorized several chapters. It's a textbook and journals and manuals relating to nutrition and dietetics. He is contributing several nutrition and health relating articles in national prints and medias. He is he received the best nutritionist in 2019 award from the Fit Up Fest 2019. He is received Sadhana Award 2020. He is contributing to the field of the clinical and therapeutic nutrition. He is also the medical nutrition therapy as a former excellency Tamilnadu. Thank you, madam. I think we want to start the program. I think good. Thank you, madam.
A very good evening to one and all here. At the outset, I am grateful to Dr. Ruba from Curie Hospital, Swaha, as well as Krishnamurthy sir, the convener of Indian Dietetic Association Chennai chapter, and the entire team of Indian Dietetic Association. I started my journey as a nutritionist in a 40-bedded hospital and moved on to a 2,500-bedded hospital in these 27 years. And when I started my journey as a nutritionist, I was employed in the hospital because two important consultants were there. One was a renal transplant surgeon. The other one was none other than Dr. Mohan. That is why they had employed me as a dietitian there, because they had a lot of renal patients and a lot of people with diabetes. So when I started my career with renal nutrition, the nephrologist took the 1 gram sachet packet and took it to the lab in the micro-weighing scale to measure and see whether I was providing 1 gram of salt in the name of the salt sachet to the patients, depending on the prescription, whether it was 2 grams salt or 3 grams of salt. I was very, very offended. When he did it, he took it to the lab and measured, and the lab technician was a good friend of mine. So she told me that the nephrologist came over and did this measurement. I'm telling you, even today, I was very upset then. But then I realized that measurement is very, very important. You know, whether it comes to salt, whether it comes to potassium, whether it comes to phosphorus, or whether it comes to calories. The entire gamut of nutrition depends on measurements, depends on portion size, depends on the counseling, depends on follow-up and monitoring. All of this put together only will help persons with diabetes with renal issues, that is the DKD, diabetic kidney disease, to reduce the morbidity, mortality, and improve quality of life. So today I'm going to be talking to you the evidence which is going to be basically based on ADA 2020 as well as the KDOKI guidelines, the Journal of Renal Nutrition. In and around these guidelines and the Indian CKD guidelines 2013. Apart from that, it will overlap a little bit of the practice what I've had in the past 27 years of working with our renal patients. I'm not able to move the slides. Hello? I have a little disclosure to make that there is no compensation received in this presentation. And basically, when we talk of DKD or diabetic kidney disease, what is our main goal? Our main goal is glycemic control, blood pressure control, lipid management, and a little bit of tinge or an add-on of how much we can motivate our patients to be physically active. All these segments are part of a nutritionist job. So when we talk of, in a cricket match, we are tossing a coin. And only one side of the coin we can see, right? So when we toss a coin, when it comes to DKD, you will see that the part of the coin what we can see is PEW. That is, both DKD or CKD are, they go hand in hand with PEW. PEW is nothing but protein energy wasting, which is nothing but anorexic cachexia. In fact, if you see the statistics, you will know that the prevalence of PEW is as high as 98% in the low income group and 63% in the high income group. And majorly 75% of my patients have been belonging to the low income group. It's only the 25% which belong to the high income group. And I see majorly the low income group which actually go on, with the prevalence. The prevalence is as high as 98% when it comes to malnutrition. I would not use the word malnutrition. I would use the word undernutrition. That's the right word which will go with the low income group. And so many of them do not even see the stage of dialysis. Before that itself, there is morbidity and mortality. So as the stage of CKD progresses, you will see PEW progresses. Now, there are several causes for this PEW. For example, you will always understand that when one walks into chronic kidney disease, it is a hypercatabolic disease. You will see that the requirement of calories in most of the guidelines, you will note that it is about 35 calories per kg body weight. What do you mean by 35 calories? We are increasing the calories from the baseline of 30 calories per kg ideal body weight. If somebody has had a normal, body mass index, normal anthropometry, then we prescribe 30 calories per kg ideal body weight. But in all the CKD guidelines, you will note that it has been stepped up by 5 calories. This tells us that this is an hypercatabolic state, or where the metabolism is raised. That is why the calorie requirement is raised. Not only that, you will note that PEW walks in because one is your requirement is high and your intake is compromised. Your intake is compromised could have thousands of reasons. It could have as simple as there is a dip in ghrelin, there is a step up in leptin. Also, there is a raise in the inflammatory markers like interleukin 6, interleukin 8, interleukin 18, CRP, TNF alpha, all of this. Apart from that, depression, economically you are really deprived. So it leads not only to depression because of economics involved, not only that, even you are not able to function, like any other normal individual, unless and until you walk into, CAPD or maintenance hemodialysis or PD, where you're trying to come back to your original physical activity and original routine functions what you used to perform previously. So basically, as I mentioned to you, there are several causes. It could be hormonal. It could be if the patient has walked into dialysis, they could lose, as low as 8 grams to as high as, 14 to 25 grams of amino acids per dialysis, depending on the number of hours of dialysis they are undergoing. And suppose, not only that, they also lose carbohydrate containing dextrose whenever they are getting dialyzed. Unless and until it is PD, when it is HD, definitely they are losing on carbohydrate also. They are losing on protein also. So in other words, they are losing calories. So as I mentioned to you, there could be other issues even like, today's Puranmashi, today's Amavas, today's Monday, today's Hanumanji ka din, Friday, I believe in Durga, so I will not eat non-vegetarian foods, I will not eat egg white. Then there are a list of restrictions given by pre-printed diet charts. Even now, it's very unfortunate to say that so many places, even now, just flash across a pre-printed diet chart to somebody who's suffering with CKD or DKD, or they have also started on dialysis. Sometimes what happens, the patients who have been counseled prior to dialysis, that diet chart is continued even post-dialysis. They don't think, probably it may be possible that they do not have the access to a dietitian, or they've not been referred to a dietitian, or the dietitian has not herself emphasized and told the patient that today I am prescribing a diet, and if you, in case you do not come for follow-up, then you may be lost to malnutrition. The reason is, once they initiate dialysis, your requirement changes and you can be a little more flexible, or there could be a little more free hand given to you on diet. So remember to come back to me once dialysis is initiated. So this small 2 minutes extra tip by telling them that you need to come back, it's important to follow up. Sometimes there could even be gastroparesis, because of which, delayed gastroemptying, or sometimes there is paralysis of the stomach itself due to electrolyte abnormalities, because of which the appetite may come down. Sometimes there are so many patients whom I've seen with cirrhosis of liver, with type 2 DM, and with the renal compromise, who suffer with, ascites also. So if somebody is consumed about 1.5 liters of water, ask them to take a meal after that. It's not possible. So somebody like that who's having with, gross ascites or even moderate ascites, he or she may not be able to take even say 50% of the meal which is required. So all these reasons could be the causes of PEW. And most unfortunate, what's the consequence of PEW is the plate almost remains empty. So if you would have really, spent enough time with your CKD patients, you would realize that the calorie intake is hardly 600 calories and the protein hardly touches 20 to 25 grams. And the reasons I've told you previously. Now, how do we intervene in such patients? Obviously, dietary counseling is important. But before you do dietary counseling, you need to do screening, you need to do assessment. And in case after your dietary counseling and nutrition intervention, or the conversion of the diet prescription to a meal plan, you're not able to meet the calorie and the protein requirements, that's when oral nutrition supplements walk in. As a nutritionist, we would never suggest anabolic hormones or anabolic steroids. That is, taken up by the nephrologist. Whether it's correction of acidosis also is handled by them. So when I talk of screening, I'm going to be touching with specific to CKD patients or DKD patients. Here, the most convenient tool or the validated tool could be MUST, Malnutrition Universal Screening Tool, where, BMI, weight change, appetite, then the total nutrient intake in the past 5 days, all of this put together will help us score the patient. Once we score the patient, we can decide whether the patient requires re-screening or reassessment or immediate nutrition intervention. Then when it comes to assessment, there are several parameters which are used for, to do nutrition assessment of a patient. See, clinical assessment, we follow something called PICCLE, P-I-C-C-L-E, in which paler, icterus, then clubbing, lymphadenopathy, edema, all of these are, clinically assessed by the dietitian. Then there is body composition analysis. In body composition analysis, the skeletal muscle mass, the lean mass, that is the fat percentage, the fluid percentage, extracellular, intracellular, water, all of them, you can easily get with the help of body composition analysis. In biochemical assessment, the routine renal parameters, apart from that, sometimes albumin, pre-albumin, CRP, interleukin 6, all of these are also measured in order to find out the inflammatory status of the patient, apart from the routine hemogram. In functional assessment, most commonly, we do the hand grip strength with the help of a hand grip dynamometer. And after this, the problem etiology S, that is a symptom. The PE statement is made, and after the PES statement is made, then what we do is we start our nutrition intervention. And the most common tool which is used for assessment in DKD or CKD patients according to the guidelines, the renal guidelines, is subjective global assessment. What I would want to tell here is, obviously one cannot complete a nutrition assessment without ABCD. in the D, dietary interview. That's very, 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 very important. Now, with the help of the dietary interview, you will identify, see, if the patient is if the person is a type 1 DM, you will know that there could be associated autoimmune disorders. There could be associated autoimmune, as it is type 1 is autoimmune. You could have associated autoimmune issues like there could be hypothyroidism, there could be even celiac disease. So that could be one particular segment. The other segment is the patient could also have lactose intolerance. So many food allergies, food intolerance, vegetarian, non-vegetarian, and what is his diet on the day of dialysis, prior to dialysis, post dialysis, all these things. Apart from that, suppose he's going for work, what are the working days and non-working days? What is his diet? It's totally different. Sometimes most of the patients who come to us, if we are when we are admitting them, they tell us that they eat better on the days they are admitted. The reason is simple: access to food. They do not get those 2 egg whites. They do not afford those 2 egg whites when they are at home. Actually, few years ago, I heard in CMC Vellore, it was a very kind gesture in which they provided hens to the patient so that they could have a regular supply of eggs. Now, when it comes to protein nitrogen appearance, you will see that this is to be used only in stable CKD patients, not in sick CKD patients. When it comes to biochemical parameters, there are, CRP as well as interleukin 6. When they are measured, they will give us a direct relationship to the number of hospitalizations, to the morbidity, mortality. When it comes to albumin, I would want to specifically say that it is not a marker of good nutritional status because it is a marker of inflammation and it is a negative phase reactant. So you will always find there is a dip in albumin whenever there is an inflammation in the system. So when we see onco patients or when we see persons suffering from renal failure, you will always find that the albumin is on the lower side. Then when it comes to subjective objective assessment, obviously the SGA is there and the malnutrition inflammation score. Between the two, in malnutrition inflammation score, we are also measuring CRP, we are also measuring TIBC, total iron binding capacity. So that's a little add-on apart from the routine in SGA, what we usually do. In SGA, obviously, we determine the intake, the weight loss, then the functional capacity. Apart from that, we also determine any fat loss, any subcutaneous fat loss, then muscle loss. All these small segments are identified with the help of SGA. And as the score of SGA is increasing, you identify that the person is moving towards malnutrition. Obviously, the advanced ones are body composition analysis. You do the BOT-POT method, underwater weighing, the DEXA, then the MRI, CT, dilutional methods, then the body impedance analysis. But I would want to still add on to say the body impedance analysis is, I do not know very surely whether it is still calibrated for our Indian physique. I still have that doubt lingering in my mind. I wish somebody could clarify that. So according to the Indian CKD guidelines 2013, no single measure should be done. It always has to be a combination of all these assessment techniques. Only then we can we can identify malnutrition with greater specificity and sensitivity. I mentioned to you about subjective global assessment. And when it comes to those patients who have a GFR of less than 20, you have to compulsorily do one of these three, definitely on a regular basis. It has to be serum albumin, though we know that it's not a marker of nutritional status, though it's a marker of inflammatory status. Edema-free actual body weight. But one thing I would want to add on, whenever we measure the weight of a patient, we should remember that if there is edema, mild, moderate or severe, you have to deduct 1 kg, 5 kgs or 10 kgs. And if there is associated ascites or only ascites, then you deduct for mild, moderate and severe ascites 2 kgs or 6 kgs or 14 kgs from the present body weight in order to calculate the body mass index. If you're going to calculate the body mass index directly, then you're going to have a false body mass index. You're going to have a false grading of being overweight or grade 1 or grade 2 obese. But mostly you will see that these patients, if you do a body composition analysis or a DEXA, will actually come to know how much of muscle mass is there and how much of fat percentage is there. Then as I've mentioned to you previously, the NPNA is only done for patients who are stable. So I've already mentioned to you, serum albumin is not a super marker for nutritional status. It does not relate to hand grip strength or DEXA or even the urinary albumin loss. But remember, whenever there is a urinary albumin loss in early stages of CKD or DKD, you need to remember to replace whatever grams of albumin you have lost in the urine on daily basis. But yes, it is a direct marker to inflammatory status. And how often should we do this nutritional assessment is, for somebody who is in the CKD stage 4 and 5, you have to do their assessment once in 3 months. And for those who have walked into CKD stage 3, you need to do it once in 6 to 12 months. But actually, in the hospital where I work, the renal ward is in the 5th floor and we are in the 3rd floor. So every time a patient gets admitted or every time he or she is diagnosed with CKD or DKD, they are referred to us without fail. Even in this COVID situation, I am still seeing CKD, DKD patients without fail. As soon as they are diagnosed, they are referred to us. And not only that, the dialysis patients, also they are given free hand to walk into our OPD anytime between 9 to 3. We have not restricted our time 10 to 12 or 9 to 11 for our OPD. We are open to all our patients, so they have easy access for any queries, any doubts, or if the nephrologist feels, no, there's something going wrong with the patient, there is an elevated phosphorus or a dip in the potassium or an elevation in the potassium with hyperkalemia, we immediately refer the patient to us. Another important thing here is the hand grip strength. There is evidence to tell us that those patients who are, without CKD, the prevalence of hand grip strength is malnutrition is as low as 6.2%. Whereas those with CKD, they have 25.2% have been found to have low hand grip strength, those who are suffering with CKD. Another important thing which needs to be documented in the case sheet is, based on the International Classification of Diseases, the 10th revision, if you mention this code, say for example, the patient previously had a code of E44.0. So we had documented in the case sheet E44.0, trying to tell that the person was suffering with moderate protein calorie malnutrition. But now the patient has a sequelae of protein calorie malnutrition. I'll explain to you. I have one patient, he's still, not under conservative management. He's walked into hemodialysis for the past 7 years. His weight was almost 90 kgs when he started off, and today, most unfortunately, he's 57 kgs. You'll be wondering that I am saying my patient. But when I say that, this particular person who's suffering with diabetes was a chronic smoker and poor compliance when it comes to dietary intake, even today. Even today, if you ask him, he's in Thane, he wants to eat batata vada, or he wants to eat pani puri, or he wants to eat bel puri. Whenever given an opportunity, he will just miss or escape from the house and walk into a batata vada shop and eat batata vada with all the chutneys possible. And sometimes before he was walking into this dialysis stage itself, he used to regularly visit the swimming pool when he was in CKD 5. The reason for that was what? He was walking into the swimming pool just to drink that water. It's very, very unfortunate. This particular person used to consume 1 liter of water per meal. And today he's got anuria. When he has anuria, he's allowed only 500 to 700 ml per day. It is so difficult. Not only this person, any person who's been restricted 500 to 700 ml of fluid per day, believe me, it's a real challenge for the family. The family gets blasted because this, I know so many other patients also who blackmail the family members and tell them that unless you give me a glass of water to drink, I'm not going to eat the meal. It's very, very difficult. And this particular patient developed tuberculosis in the, oral cavity, and because of which his nutritional status further came down. And today I would say that there is M62.5. The reason being that he has hospitalization every month for fluid overload. It's very, very unfortunate for such people to be moving on. Their quality of life as well as the quality of life of their family members is a real dip. What are the goals? Obviously, we want the blood pressure, the blood sugar, the dyslipidemia, all of this to be controlled. But remember one thing, where there is requirement of weight loss, you have to think of weight loss, and where you have to think of weight gain, you have to think of weight gain. I would always want to mention one more little thing. We always tell our patients or persons suffering with diabetes, all the PWDs, that we want a weight loss of 5 to 7% according to the Finnish diabetes study. That if you reduce 5 to 7% of your present body weight, definitely your insulin resistance comes down. Once your insulin resistance comes down, your insulin sensitivity improves and there is good glycemic control and the progression of CKD halts. That's a very good thing. But at the same time, once you have achieved this, if the patient is just on the overweight side, just leave him alone. The reason is, once he is moving CKD 5 stage, then it is too late for you to think of further progression is going to be there or no. Allow him to hold on to that weight because that is his fixed deposit, which will take care of him when he is walking into dialysis and when it's going to take him 3 months or 6 months time for him to recover back and come back to at least not to the original weight, at least to 75 to 80% of the weight. And when his 80% of the weight is maintained, he'll fairly do well. Otherwise, you will see recurrent admissions in the hospital. So optimize glucose control. Now, according to ADA as well as the KDCO guidelines, the expected thing is we have to monitor the blood sugars. We have to monitor their HbA1c. And what HbA1c do we want? You know, in the early stages of CKD, we want less than 6.5, less than 7% without hypoglycemia. If there is hypoglycemia, then probably we need to be a little more relaxed. But once the patient has walked into end-stage CKD, you will find that there is so much of brittleness in the diabetes. There is so much of glycemic variability from hypos to hypers, and especially when the patient is not following up on regular basis. It's very, very unfortunate to understand that if the person with diabetes has not regularly followed up with his or her endocrinologist or diabetologist and following a particular set of medications. For example, if the patient was on metformin, as continuing the metformin, even when the creatinine has touched somewhere about 6, you know, not even bothered to follow up. That's why probably the reason for this DKD. And he is going to go into recurrent hypoglycemia. So in that case, hypoglycemia can precipitate a myocardial infarction, which could be very, very dangerous. So depending on the stage of the CKD, we need to relax our HbA1c target. Another important thing is time in range. According to the time in range, we want at least 70% of the values to be within the target range. Now, no ideal percentage. So now we are walking into medical nutrition therapy to handle the glycemic control. So obviously all of us know that there is no ideal percentage of calories from carb, fat and protein. It needs to be personalized. In other words, the word ATP. It has to be based on assessment. It has to be tailor-made, and most important, it has to be practical. Obviously, there could be somebody with gluten sensitivity. There could be somebody with, IBS, or there could be somebody with IBD. There could be a host of issues. So you need to be a patient listener first. Only if you are a patient listener, when you do your 24-hour diet recall or your food frequency questionnaire, you will be able to gather data and help the particular person. For example, when you take a data, you will know that the patient has been consuming black tea or green tea, or consuming a concoction of several powders like fenugreek, then the chia seeds, flax seeds, whichever they hear that's very healthy, very healthy. If they would have walked into CKD stage 4, stage 5, then they are not going to be doing good to themselves. So it has to be individualized specifically. Now, when it comes to type 1 diabetes, it's a very, very difficult situation. The reason being that they are already on insulin. So many of them would be on pumps, so many of them would be on pens, so many of them would be just on insulin injections without the pen or the pumps. So in those cases, you have to be emotionally working with them. That's very, very important. When I say this term emotional, I would want to share one personal experience with one of my patients. She's unfortunately, not unfortunate, she's a transgender, and she's been following up from the time she was diagnosed till today. She is on dialysis. And whenever I used to meet her, and she had anuria, whenever I used to meet her, I used to ask her, so how are you doing? She's like, Amma, I'm feeling well. I said, you lost weight, or you're looking better. She would respond to me immediately, and she'll look up wherever she is and she'll tell me a hello. Recently, she was crossing past by me in the lift. I was walking out of the lift, and she was crossing past by the lift, and I asked her, hey, you couldn't recognize me. How are you doing? She's like, Amma, I can't see you. I'm like, what happened? She said, I lost my vision. There were a sequence of events why she lost her vision. But she could recognize me and say, hello, Diet Amma, how are you? That is the connection what we have with our patients. So I think emotionally you have to get attached, whether it's your type 1, type 2, or just the CKD patients. If you are emotionally attached, they develop a confidence in listening to whatever you've got to tell them. You know, they will believe it as God's word and they'll follow you every bit. I have one particular PWD who's about 70 plus. He was referred to me from the onco department. He had anemia and his urea creatinine was about 70 and 2.70 urea, and creatinine was 2.3 something. His HB was around between 9 to 10. And obviously he was a diabetic also, non-Hodgkin's lymphoma. So he was undergoing chemotherapy. He was referred to me. Today, after 5 years, we have completed everything, but he believes in every word we tell him. When he believes in every word we tell him, we have seen this, his urea creatinine has come down to near normal and he lives a life very comfortably with good blood sugar controls, with good HbA1c. And even sometimes when he has no choice, he's not able to come to us to the hospital, he goes elsewhere, he comes back and tells us, Madam, I went there, after going there, I relaxed a little, diet a little bit, because there they never insisted for me to have a very consistent and a strict diet. See, my potassium is raised, my phosphorus has raised. But when I come back to you and I follow you diligently, definitely I'm doing very well. So this is a very important message which also, makes the dietitian feel good that you're in the right track and your patient is also in the right track. So which diet do I follow? There are several diets, from ketogenic diet to people with follow intermittent fasting, Mediterranean diet, a host of diets to help their good glycemic control. Because they want to lose weight, to bring down the insulin resistance, they follow thousands of diets. But there is enough evidence to tell us that the Mediterranean diet or the DASH eating diet does wonders. Along with that, a dip in the SFA to as low as 7%, nil trans fats, omega-3 fatty acids will do wonders. Obviously, the fiber and the plant. But when I talk to you about plant protein, and fruits and vegetables, we have a recent paper which was published about 2 days ago, which tells us it does wonders for people with diabetes and kidney disease, that is a DKD, in the sense that there is cardiovascular protection also. And most of these PWDs suffer with constipation. Reason is, intake is obviously inadequate. Their fiber intake is also compromised because they don't feel like eating, as simple as that. Maybe even if they are aware that it's healthy, they don't feel like eating, or probably they have been prescribed diet in which the person says that your potassium is high, so stop fruits, stop vegetables, stop salads, where they should have actually ideally told stop fruit juices and stop soups. Instead of saying that, they've said stop fruits, stop vegetables, stop salads, but instead of giving options where they could consume, cucumber about 50 grams, which would be about less than 100 milligrams, tomato about 50 grams, which would be less than 100 milligrams of potassium. Or, right now, if you look at IFCT 2017, there's hardly any vegetable which is left, which is low potassium other than the chow chow. But most of the vegetables fall into the high potassium category. So I would say that there is evidence to tell us that when you boil vegetables and leach away the water, obviously not once, 3 times, or when you pressure cook them once at 70 degrees, obviously it touches 70 degrees when you're pressure cooking, 1 whistle, and you discard the water, the potassium comes out. Also, you leach away the phosphorus. So these 2 things are very, very important. But one thing you need to remember that plant proteins, when they have phosphorus within them, the phytate do not allow the phosphorus to be bioavailable to the system. So that way we are a little blessed also. So I would say that whether it's the KDIGO guidelines or the ADA guidelines, they follow the similar pattern for glycemic control. Now, when it comes to the Mediterranean diet, I would want to say there is a disturbance. If the tech team could just check there is a disturbance. Okay, I'll just continue. So when it comes to the Mediterranean diet, remember the 3 P's, the protein, the phosphorus and the potassium. And it's also not practical to have 5 to 10 servings of fruits and vegetables in an Indian scenario, probably in a low income group or a middle income group. And remember, if you are walked into CKD stage 4 or stage 5, you're definitely your phosphorus and your potassium is going to be, under check. So is a Mediterranean diet ideal when it comes to DKD 4 or DKD 5? It is a question. Your biochemical parameters with potassium and phosphorus will allow you to tell that. And I'm sure 5 to 10 servings in combination with fruits and vegetables is going to be an issue when it comes to glycemic control. You cannot be having 5 servings of fruits and saying that I would have good glycemic control. So you need to remember glycemic index, glycemic load of a particular food. When it comes to fruits, I would say WAP, watermelon, apple, pear, pineapple. All these fruits fall between the, moderate GI to GL, which is moderate to low. So which can be easily consumed by PWDs or the DKDs. 75 grams could be about 3/4 of their handful, which is conveniently consumed where you will find that the potassium is less than 100 milligrams. So remember WAPP, watermelon, apple, pineapple, pear. Any one of them can be had, but usually when you see the My Plate, even if it is the Jocelyn's My Plate, it tells you take the fruit along with the meal. I would say for those who are having PWD, do not take it along with the meal. Take it in between the meal, mid-morning, evening, or bedtime, or before a walk, or after a walk, so that your postprandial peak does not come in. Now, another important thing when it comes to oats, there was this paper which was published in 2019, which does tell us that when the diet is supplemented with beta-glucan, it helps to reduce the progression of CKD. But if the PWD or the DKD is within stage 3 and potassium and phosphorus is not an issue, oats, especially the rolled oats or the steel cut oats, not the instant oats, they could be added to the dosa batter or to the wheat flour in order to step up the beta-glucan content of the diet and help to improve not only glycemic control, also reduce the TMAO in the patients as well as reduce the progression of CKD. Always somebody who is stage 1 to stage 3, I would say follow the Zimbabwe hand jive. Not all patients are educated. It's easy to tell them that if you're taking a fruit, take a fruit which fits into your palm. And if you're taking vegetable, it has to be 2 handfuls. If you're taking protein, it has to be within the palm size. Obviously, depending on the stage of CKD, as it's progressing, the protein requirement may slightly dip. And when it comes to vegetables, as I've already told you, you need to take 2 handfuls. Depending on whether the potassium and the phosphorus is within normal limits, you have to think of leaching or no leaching. And obviously, the fat portion has to be the healthy fat, avoid trans fats, and avoid saturated fat. When it comes to chew count, it's important. In Lancet, there was a paper which was published which did tell us that one spends only 26 minutes throughout the day chewing your meal. It's very important to chew your meal in order to nourish your cells, to have satiety, and in order to have your postprandial peak down. And recommendations for treatment of nephropathy patients, I would want you to be very cautious when you're reading this. I'm just reading it carefully. Those persons with diabetes, with diabetic kidney disease, who have an albuminuria of greater than 30 milligrams, you need not reduce the amount of dietary protein much below the usual intake, because there's not enough evidence to tell us that there is a dip, there is an improvement in the GFR, or the cardiovascular risks come down by bringing down the protein intake. So it has to be rationalized depending on your macroalbuminuria or macroproteinuria. Depending on the raise in the urea and creatinine, you will think of the protein. I would want to mention one particular person who was in the bargain of losing weight. She went to Kerala for some Ayurvedic treatment. I think it must have been a quack Ayurvedic treatment, because in 1 year's time, she lost about 50 kgs. And when she lost 50 kgs, it was unfortunate. She was also associated with consuming 150 grams of protein per day. So I think her renal function did decline in that 1 year, probably a combination of Ayurveda as well as the 150 grams of protein. And when she was put on dialysis, we had to tell her, you need to step up your calorie intake. You're taking hardly about 300 to 400 calories a day. Her answer to me was, ma'am, if I increase my calorie intake slightly, even by increasing 1 portion of rice or 1 chapati, how many grams of weight will I gain? So the mental status of a patient and the choice of, lifestyle modification is very, very important. That is where, you would have to think of protein restriction, not in a routine situation where the albuminuria is greater than 30 milligrams per 24 hours. So usually the prescription is you restrict the protein to 0.8 grams per kg body weight per day, provided the ACE inhibitors and the ARBs are not still reducing the albuminuria. You know, still there is, from microalbuminuria, there is macroalbuminuria, and there is a progression of your decline in your GFR. Then you have no choice but to bring down the protein to 0.8. There was a time when they were restricting the protein to as low as 0.6 grams per kg per day. This is also, even now I would want to mention that some PWDs, even today, even if they are type 1s, they follow the ketogenic diet. It was very, very unfortunate when I got to speak to somebody yesterday, and she was telling me that in a particular diabetes reversal program in Chennai, they are not even screening the patients to see whether they have renal issues or hepatic issues, and simply, you know, blindly providing them a ketogenic diet, only worrying about weight loss and glycemic control, not worrying about the other important organs. That's very, very unfortunate. So this has to be kept in mind, that such things have to be done under a supervision only for a short period of time, not somebody who's already having micro and macrovascular complications of diabetes. Probably this could be thought of in early stages of diabetes, you know, just been identified, and you're young and you're not following a strict ketogenic diet, but following a pseudo ketogenic or a healthy form of a keto vegetarian diet, which should only do good to you, but not misuse the diet, you know, and ruin your organs. The reason being that there is dehydration, hyperuricemia, nephrolithiasis. In fact, I remember one PWD who was a vegetarian and who took about 12 bananas a day for afternoon, and breakfast was only dates, coconut, and dinner was again raw vegetables, fruits, salads. He lost about I think 7 to 10 kgs, and then gave up on his anti-diabetic agents, and suddenly got admitted with UTI and acute kidney injury. So these things have to be done under supervision, and it has to be done only if warranted, not otherwise. And so my plate usually is little different when it comes to the CKD, but my plate usually suggests make half your grains whole. But remember, whenever somebody has walked into CKD4, that is DKD4 or DKD5, with issues with potassium and phosphorus, you cannot suggest oats or ragi or little millets, because obviously you cannot leach them. And one has to understand ragi has about 443 milligrams of potassium. And the phosphorus is also almost 4 times. That is, when I say 4 times, it's almost within the 400 range. So usually wheat has potassium and phosphorus in the ratio, it's on the higher side, much higher side. I think it's about 300 milligrams when it comes to potassium, and phosphorus around 300 to 400 milligrams. When it comes to rice, it is about every gram of rice has about 1 milligram of potassium and 1 milligram of phosphorus. But it's easier for us to leach the rice to remove the phosphorus as well as the potassium. I understand the B vitamins are lost, but most of them are supplemented with B vitamins supplements. And milk also, you always remember that every time you provide 1 ml of milk, you are providing 1 milligram of potassium and 1 milligram of phosphorus, and that cannot obviously be leached. So I've read some literature saying that the paneer which is prepared has slightly lower potassium, but I really do not know whether the potassium is leached off in the whey water. That is why the potassium is about 65 or 67 milligrams per 100 grams of paneer. I'm not very sure of that. But as I read it in some literature. But so you need to remember, you cannot advise those who have walked into stage 4, stage 5 with, you know, replacing rice with little millets or with oats or with ragi. Definitely they are not a good bet. And suppose they are having associated hypothyroidism in the early stages, you need to remember to roast them, sprout them, or ferment them. Otherwise, they would prove to be goitrogenic. So what do we take, the plant protein or the animal protein? I would want to say here is, I would want to read each of them because each of them has value to understanding. Meat-based diet increases the acid loads. It's increased risk of ESRD. Not only that, they are a source of saturated fat as well as a source of phosphorus. The phosphorus from plant is less well absorbed, obviously because of the phytates present in them. The plant-based diet that are alkaline and increases the insulin secretion promotes fecal excretion of potassium. So they are very good. But remember, it is also associated with potassium also. Then the plant-based diets are suitable if the GFR is between 30 to 59. As I mentioned, it should be in 3A or 3B, that is the grade 8, 3A, 3B of CKD. Then you think you can manage a plant-based diet beautifully without worrying of the potassium as well as the phosphorus. So this is obviously known fact that every time you talk of protein, phosphorus walks into it. So it's a real challenge when it comes to those patients who are undergoing dialysis. That's why we think of oral nutrition supplements. When it comes to keto analogs, the more the keto analogs you are going to be consuming, the lower the protein you are going to be taking. But personal experiences, I find it very, very difficult to bring down the protein to 0.5, 0.3 grams per kg. Very, very difficult. It sounds very easy on paper, but very difficult practically. And also remember, when it comes to sodium, obviously no processed foods. But when you look at a nutrition label, if the sodium content is more than 1 milligram per calorie, it indicates, it's a clear-cut indication that the sodium, the entire food, processed food, is very high in sodium. Usually I tell my PWDs, that is, you restrict your salt. If you're normal, you're just a diabetic, you know, you have no complications, you take about 4 grams of salt with hypertension. With once you're walking into CKD, you reduce the salt to 3 grams, and when you're progressing further, you reduce it to 2 grams per day. Now, obviously, if you bring down the salt intake by 30%, you are going to save your kidneys. The ICMR WHO tells us that you need to restrict your salt from 10 grams to 5 grams. But as I mentioned to you, in DKD, you progressively reduce it to 5 grams to 2 grams, depending on the progression of the disease. So I would say the term controlled salt DEL. So no pickle, papad, you know, all the instant food, canned food, processed food, anything which has got invisible sodium in it, invisible potassium in it is out. And if you look at this different types of salt, it will tell you that the table salt is the least in the potassium. Though in early stages where potassium is not a worry, I usually suggest my patients to take, low sodium salt where the potassium is there. So that will help to improve the blood pressure. But then when they are touching 3 or they are on potassium sparing, diuretics, then you need to worry about the potassium from the salt. Otherwise, the regular table salt in reduced quantity would do wonders. So this is a small exchange list, which is a part of my textbook, not textbook, it's a handbook of food exchanges, where I have given the entire exchange list for the various food groups. And this is what I was telling you, that when you boil the fruits and vegetables, it significantly reduces the potassium. But it is based on your recall, you will identify whether the patient requires potassium restriction or no, whether the patient requires leaching or no. It cannot be given as a blanket prescription. Now, these are certain food additives based on this paper, which was published in 2013. That is, all foods containing sodium nitrate, aspartame. Remember, it's a sweetener which is used by so many of the PWDs. So aspartame as well as asulfame potassium should not be used. But apart from that, so basically, if you say processed food, no processed food. That's the bottom line for this. So artificial sweeteners, I've mentioned to you, the safest could be sucralose or, sucralose could ideally be the right one. But remember, whenever you use artificial sweeteners, it leads to gut dysbiosis. And in the long term, it will definitely impair your glycemic control. So if you're going to manage without sweeteners also will do good. But another important thing when it comes to our PWDs, as they are walking in slowly, as their DKD is progressing, you will find that they're developing regularly, moving into hypoglycemia. The reason being, they are anti-diabetic agents. If they are on certain anti-diabetic agents which have an excretion route via the kidney, then it's going to remain in the bloodstream for a longer period of time and going to give you recurrent hypoglycemia. So in that situation, I do allow, even the ADA allows 10% of the total energy intake coming from carbs from simple sugars. In those conditions, we do tell our PWDs that you can take some amount of sugar in your beverages, but obviously the beverages should come within the fluid restriction. And I usually suggest not to cross more than 300 ml in case of a non-vegetarian patient for milk and milk products. And in terms of vegetarian, I suggest them they can step up to about 350 ml per day. And I would want to add, especially this particular slide, reason is that if you can prevent GDM, that will do wonders, because GDM is a significant risk factor for long-term maternal renal disease. In fact, in my entire practice years, I have seen one type 1 who was suffering with CKD, and when she was pregnant, it was a real task for us to, handle it. And she had a history of bad obstetric history also. But somehow we managed her for the 9 months with insulin, with nutrition management, and she delivered, I think, almost a 2.75 kg infant, full-term infant. So I would want to mention this particular case study wherein I would say that one Mrs. X came to me with fasting blood sugar 350 milligrams, urea was 53, creatinine was 1.3, HbA1c was raised, she was newly detected, and her blood pressure was 130/90, urine albumin was 2+. Just because the urea and creatinine is slightly high, I will not plunge into a renal diet immediately, because when there is hyperglycemia, there will be false urea creatinine values. And this albumin U2+ could also be concomitant with urinary tract infection. So once the patient has been screened for UTI, the blood sugars have been brought under control, say probably after 2 weeks or 3 weeks. Once I repeat the urea and creatinine, you will see that there is a dip in the urea and creatinine. It's almost near normal. If it does not dip to near normal, then probably you will have to think of a renal intervention. So this particular patient was also, say about height is 168 centimeters. I've already told you that how you need to calculate the dry body weight. The fasting blood sugar was only 45, urea 86, creatinine 3, serum sodium was 153, potassium 2.2. This is frank CKD, end stage CKD. Total protein was only 3.9 grams, output was only 200 ml, blood pressure way high. What was the total recall? Half masala dosa or pongal, half cup, 4 to 6 good day cashew biscuits or Monaco biscuits, 1 cup of coffee, 3 spoons of rasam rice with pickle and papad, and ONS only 50 ml per day. So this was the total calorie intake. And this patient's serum sodium was way high. Probably the pickle, the papad, and the biscuits did their job. But the biscuits didn't seem to improve the serum potassium. But I hope I'm not sharing the message across. This could be a special situation where the patient's serum potassium was only 2.2. Otherwise, with the consumption of probably 4 to 6 good day cashew biscuits, I may expect a raise in the potassium value. But since the patient was taking only very small quantity, you will see that the fasting blood sugar is only 45 milligrams per deciliter. So much of digging has to be done before you make a nutrition prescription for such a patient. Here, obviously, what will you do? You will even allow the patient to add sugar to the diet, add some fruit, probably not 1, even 2 fruits a day, because they are not worried, even the potassium is on the lower side. But remember, we have to pull off the pickle, the papad, the biscuits, and step down the salt intake. And here, since the output is only 200 ml, remember that the fluid restriction should be there not more than 700 ml. The blood pressure would come down once you are going to make this nutrition intervention. And the reasons for admission was patient was drowsy because of hypoglycemia and shortness of breath, because of probably there could have been fluid overload because there was restriction of output was only 200 ml. So I would say strategies for improving care based on nutrition care process would be, it should be done timely. You have to timely intervene after you've identified malnutrition. It should be based on preference, prognosis, comorbidities. Somebody is having a denture or somebody is associated tuberculosis. Based on that, you need to make those slight changes. Literacy is very important. Literacy in terms of understanding as well as numeracy. They should understand numbers also. It's difficult to understand numbers when they have to follow a particular diet video. So make it more practical for them to understand it so that they can follow it. Don't give them a chart which is not practical, which they are not going to follow, because even that 10 minutes or 15 minutes you've spent with the patient is of no use. I would say if you want to prevent DKD, waist circumference less than 80, fasting blood sugar less than 80, diastolic blood pressure less than 80, LDL less than 80, HDL greater by 80 divided by 2, TJ less than 80 into 2, that's less than 150. BMI should be less than 20. Greens and vegetables should cross at least 500 grams per day. This is for normal DM, not DKD. The fish should be 18 to 5 grams per week. Dietary fiber should be at least 14 grams per 1000 calories. Salt should be as low as 4 grams when you've not walked into DKD. When you walked into DKD, obviously it's restricted to 0.8 grams. Oil should not cross 480 ml, 500 ml per month. And exercise should be minimum 20 minutes per day. Thank you for your patient listening. I would say nutrition therapy, we can do it. Timely nutrition therapy is essential to prevent or treat malnutrition and improve survival. I would say a nutritionist can make a difference in the life of a PWD or a DKD. Thank you for your patient listening.
Thank you, ma'am. Thank you so much for your excellent speech. I think all audience got very nice response. All are very happy to attend your session, ma'am. So we'll take all the question after the session, ma'am. We'll go for our next session, and at last all question answer will just finish. So we are going for our next session. Our next speaker is Dr. P. Nazni, Professor and Head of the Department of Nutrition and Dietetics, Periyar University. She pursued her MSc Food and Nutrition in Bharatiya University and PhD Food Science and Nutrition from Avinashi Ningam University, Coimbatore. Her area of specialization on millets, nutraceutical properties, diabetes, sports nutrition, geriatric and pediatric nutrition. Under her guidance, a huge number of students completed their PhD. Sometimes words can't express our immense gratitude towards a person. Today I am facing short of words to express my immense love and respect that I have for you right from the time I appeared in your first class. As a very proud student of you, I am welcoming you, ma'am, for the session. Over to you, ma'am. As far as we can hear you. You kindly unmute yourself, ma'am. Yes, ma'am. Now you can speak.
Good evening to all. It's really a pleasure to be here. I thank the Curie Hospital and my beloved student Swaha for giving me this wonderful opportunity to share the product formulations, what we did in our laboratory. So once again, I thank for this opportunity.
Kindly click the screen option, ma'am.
Yes, right. It's not showing me. Wait. Is it there visible?
No, ma'am. Till now, not visible.
I'm not able to see the. Oh. Is it there visible?
Yes, ma'am. We can see, ma'am. You can start.
Yes, once again, good evening to all. I hope the speech which was given by Ms. Meenakshi ma'am is entirely different what I am going to speak with you, because madam has given all elaborate concepts about the nephrology and the role of this salt and everything. The topic posted on me is about the product formulation, as it is has given a wide value or meaning. Here I am concentrating only on the foods which we developed based on millets for the persons with diabetes. Yes, everyone know what is diabetes, types of diabetes, symptoms and everything. This slide just give a glimpse what are the key aspects of managing the diabetes. You can say, as everybody know, monitoring blood glucose, follow up a proper meal plan, taking medications and getting regular exercise, which all in all will go and keep your goal to have a good control on your diabetes. So as you know, people with diabetes, there is no simple solution. As a single solution, we can achieve this thing. Definitely each and everyone should follow this 3 Ds. Those who are with this diabetic complication like diet, drug and daily activity. In that we are going to discuss about the diet, particularly the product formulation for diabetes with the millets. So this importance of proper diet in diabetic patient is this which is shown in the slide, to provide adequate nutrition, to have a good control over blood sugar and lipids, and also to maintain a very ideal body weight. And also the other target is to reduce the intake of medications as well as to prevent the complications. As everybody know, all the major nutrients has played very vital role in the carbohydrate counting in the diet plan of diabetes. So here you can see the role of carbohydrate. As you know, the simple sugars are more prone to increase the glycemic index of the diabetic populations when compared to the complex carbohydrates. As I have given here, the simple sugars maybe from sugar, jaggery, honey, jam, and all these things, and the complex sugars are those all with the outer layers like whole cereals, whole pulses, and all. As everybody know, 55 to 60% of their total daily intake of calories will be from the carbohydrates. And the next major nutrient to be concentrated on this is protein. As everyone knows that high biological value protein shows very useful, found very useful when compared to the low quality proteins. The high quality proteins as all the proteins which we receive from the non-vegetarian sources, and as 10 to 50% of the daily total daily intake of calories should be from the proteins. And about the fat, hopefully you all know that there are various types, and saturated like butter, ghee, coconut oil, and that has to be consumed in moderation when you are identified with diabetes. And monounsaturated and polyunsaturated can be considered, but that also we have some limitations. About 20 to 20% of the total daily intake of calories be from the fats. And about the dietary fiber, you can say dietary fiber is has vast area to discuss, as we can say that soluble dietary fiber, insoluble dietary fibers, amylose, amylopectin. So everyone has its individual role to play in the reducing the blood glucose level. As all the millets what we are discussing now are having a rich fractions of this resistant starch, soluble, insoluble fiber, soluble fiber, and all these things. So as mentioned, diabetic patients should have at least 25 gram of this dietary fiber per 1000 kilocalorie of their daily intake. So what will be the modifications? Here this slide shows you the liberal use of foods like vegetables, green leaf vegetables, and high fiber foods, where I have mentioned exclusively millets, and foods with moderation, and also foods to be avoided when we are in diabetes. So next we'll go millet. Why millet? As I discussed earlier, in my today's presentation, I'm going to concentrate only on millets and the products formulated in using various types of millets for the diabetic subjects. So why millet? As this slides give you a detailed description, as this is a crop of drought resistant, and they are easily available in nowadays. It's really very easily available, and they are high in protein, vitamin B, iron, and all nutrients, and it is exclusively gluten free and rich in antioxidants. So every millet has its individual benefits. You can see left side of the slide, left side of this in this slide, which shows sorghum, which is resistant to drought and heat, and it improves the metabolism. When you go down, you can see the pearl millet, which has its different nutritional value, and it exclusively helps in minimizing the type 2 diabetes. Again, you can see the foxtail millet. It is also shows control diabetes and sugar and cholesterol. And you can see ragi, which is very rich in calcium and protein. Again, it also shows it's high in antioxidants, and it has anti-diabetic properties. So you can see most of the millets, barnyard millet, and it is also has low glycemic index and helps in type 2 diabetes. So this slide is really impressive, and then we can say all types of millets has its exclusively properties, but among the exclusive, one common property is to reduce the glycemic index. So why we concentrating millet against type 2 diabetes? There is nothing surprising. So we can say in millets, we found an important mineral called magnesium, which is abundantly available in that, which helps in increasing the efficiency of insulin and glucose receptors and thereby preventing this diabetes. So millets are all rich sources of magnesium, a mineral which is very extremely important for starch digestion, and also it helps in carbohydrate digesting enzymes and which helps to manage the insulin action. So researchers find that the magnesium rich whole grain consumption will definitely helps in reducing the type 2 diabetic subjects. And there was a research study also which indicates there must be a 30% reduction in diabetes when compared to the people who have not consumed the food without not consumed the food without. So this is a take home message. I have lot of recipes. We have prepared lot of recipes. Based on the time constraint, I may not be able to give an elaborate slides. What is the procedure, how we did, and all these things. So just to take home message, in all populations, definitely managing weight, foods with overall diet quantity, which is very important, both quantity and quality, because my previous speakers has given elaborate things, and focus on foods but not very isolated in the nutrients, and consider overall eating patterns to control or manage your diabetes. So non-dairy factors are also important, like physical activity, smoking, other lifestyle, as we have seen in the first slide, which is a key factor for controlling the diabetes. Even though 3 Ds we are concentrating, but this physical activity and other lifestyle factors also plays very, very important role in our thing. And people with risk of type 2 diabetes, and even people with type 2 diabetes, have to definitely concentrate on the dietary pattern with the low glycemic index foods to manage our glucose level. To conclude, world over, increasing number of NCD is leading to commercialization of the millet products, which is a very much need of the heart, and ready to eat food industry come forward to provide, because nowadays all are very busy. Both husband and wife are going for the job, and there is a need for ready to eat foods which provides you more nutritive value, as well as nowadays everybody is more health conscious, and they want all the foods to be nutrition and with a more nutraceutical properties. So public-private partnership also helps better for this commercialization. And among all, definitely we have to encourage our farmers who are completely rely on this type of foods. Their livelihoods are based on these foods. So thank you for the opportunity. Millets and all concept to adapt a new change. Thank you for your attention.
Thank you, ma'am. Thank you so much for your excellent presentation. We got few questions also, ma'am. I will just ask you right now. Ma'am, am I audible to you?
Yes.
Yes, ma'am. So we got a question, and that is consumption pattern of millets and acceptance of millets.
See, consumption pattern of millets is it's widely huge. That's what I'm insisting in my last slide. You can see in my last slide, even though it is not consumed as such, we need to process. The processing technique has to be adapted widely. So, and also we have to try more number of foods with the processed millets to get incorporated. But I hope the consumption pattern is really vast. That's what you can say. Barnyard millet, whatever type of millets, it's packed in the shops.
We are coming to our next question, ma'am. That is, which variety of millet has lower GI?
Which variety of millet has low GI? See, every millet has its own concept, as I am discussing. One thing is, each and every millet has different layer of coatings of brands. So whether you are using it as a whole millet or it is the devour of the brand plays very important role. And type of cooking also plays very, very important role in increasing the GI. So depending upon that only we can decide the GI content. But those millets which is used along with the seed coat, will definitely helps to reduce the glycemic index. I hope that will be a good option for the low glycemic index.
And next question is how to calculate GI index.
How to calculate GI index? I hope this every nutrition student, even a basic student, will know how to calculate the glycemic index.
Yes. The question also we got. We'll go for the next question. That consumption of fenugreek seed in diabetes.
This is for who? For me or for madam?
For you, ma'am. Just now we received the question.
Repeat the question.
Just now we received the question from Ishtai H. She's asking the consumption of fenugreek seed for diabetes. It will be good or not?
See, again, we among the various studies on literatures or even based on our own experience, consumption of fenugreek seeds is really helpful for the diabetic, because that is the only food ingredient which has a huge amount of soluble fibers in it. So I hope it is very useful.
Yes, ma'am. Thank you so much, ma'am, for your excellent presentation. Now, we got very interactive session also. You just attend all the questions. We have few more questions also, ma'am. We will try to attend all the questions later. We will just post the answer later. Now we are going to some question also here for Meenakshi ma'am as well. I just want Dr. Krishnamurthy sir to come and start the question answer session for Meenakshi ma'am. Sir, can you hear me? Krishnamurthy sir, can you able to hear me? So I am starting the first question, after that sir can join. So our first question is, if the patient is diabetic with CKD and above 70 years, what is the dietary management to be prescribed? Patient was done, the question was done by Preeti Sharma.
Yeah, I've actually, can you hear me? Am I
Yes,
audible? Okay.
Yes.
I think the whole presentation was that only, that depending on the progression of CKD, if the patient has walked into CKD third stage onwards, then we need to restrict the protein to at least 0.8 grams per kg body weight. And
Yes,
yeah, and the sugar or sugar containing food also I've answered in my session. That is, you can take 10% of your total energy intake from carbs coming from simple sugars. But in case if there is hyperglycemia, no, continuous, always there is hyperglycemia, the target range sugar is not there, then I don't think you can give visible sugars. Then it's not logical to give visible sugars. But otherwise, if the patient is doing fairly well and incorporating enough of vegetables in their diet, enough of physical activity, about half to 1 teaspoon of sugar is not going to harm the patient.
yes, ma'am. So we are coming to our next question. That is, how to manage sarcopenia in stage 4 renal diabetic patients.
Stage 4 renal diabetic patients, sarcopenia, one is physical activity. That's important, that the patient has to be physically active. That will improve the muscle mass. And obviously, you cannot reduce the calories too much. You know, if you reduce the calories too much, you are not going to have protein sparing action. So you need to step up the calories in order to meet the calorie requirement, so that your muscle mass is retained. And in case in CKD4, you're not able to, you know, actually consume enough, then oral nutrition supplement is the only way where you can pick up the protein intake without protein and calorie intake with the fluid allowance without increasing the potassium and the phosphorus. But you have to choose on low glycemic index and low glycemic load renal and glycemic friendly supplement, because there are certain supplements in the market which are renal friendly but are not glycemic friendly.
Yes, ma'am. We are coming to our next question. That is, what type of protein need to be given importance in very low protein diet? Question was done by Ruma here.
Very low protein diet, obviously you will think of high biological value protein. I would want to share one important message here is, usually we tell our patients to consume egg whites. Okay, they are the best source of high biological value protein without stepping up the potassium and the phosphorus greatly. But if you take one whole egg, which is approximately say 42 grams, usually being in government service, we are used to, you know, standard weighing is you should have a minimum weight of 42 grams. That's why it's registered in my head. a 42 grams whole egg will provide almost phosphorus 86 milligrams and potassium 56 milligrams, which will give you fairly 6.6 grams of good quality protein. But you cannot go on giving, whole egg if there is associated dyslipidemia, there is already comorbidity of coronary artery disease or CVD, and your other diet is also going to provide you potassium and phosphorus. Then you can think of only egg whites. Obviously, milk is also there. You can think of even milk, but restrict it to 300 ml because the potassium and phosphorus, as I mentioned to you, 1 ml will give you 1 milligram of potassium and 1 milligram of phosphorus. Keeping the calculation in mind, you can do it.
Yes, ma'am. Our next question is, when diabetic renal patients has pregnancy, how to manage the diet to prevent nutritional deficiency?
See, usually we step up the calories in the first trimester. We don't step up the calories. But if the patient is having end-stage CKD and pregnancy and diabetes, then you need to step up the calories by 5 calories per kg body weight for the first trimester, because here is we do not want loss of lean muscle mass. And when you are stepping up the calories, obviously the calories will come from carbohydrate, fat, protein. That time, if you are giving the carbohydrate also is adding on, you need to think of insulin coverage accordingly. And in the second and third trimester, obviously you will add another plus 300 calories to the first trimester calories. For example, prior to her pregnancy status, she was consuming, say, example, 30 calories. You're stepping up the calories to 35 calories in the first trimester. This 5 calories is to handle the end stage CKD. Then in the second and third trimester, you will add another plus 5 calories. So it will become not 5 calories, sorry, you will add another 300 calories to the existing 35 calories per kg ideal body weight, so that you will handle the calorie part of it. Now, when it comes to the protein, we say 0.8 grams, but I think you will have to merge between 0.8 and 1 gram. But if you think it is going to progress into, moving very fast, then only you'll have to think of managing it with dialysis. But if the patient requires dialysis, only then. So try and manage to keep the protein at least 0.9 grams to 1 gram, so that you are able to help the fetal development. But prefer 2/3, 50% of it coming from high biological value protein.
Thank you, ma'am, for your inputs. So we have many more questions, ma'am, but we are running short of time. So we came here end of the session. We'll try to attend all of the questions later, and we will just mail you after getting the question from our experts.
I would, before we wind up, I just want to say one important thing. People who are, say the girls or the students who are following, exchange lists, please switch over from NIN to IFCT. The NIN, where the IFCT was published in 2017 by National Institute of Nutrition. Please follow that textbook and that handbook of values, nutritional values, and not the old version. Because, for example, orange, which was only 9 milligrams, has now become almost 167 milligrams per 100 grams. So like that, the foods which were previously, consumed were apple, guava, papaya, pear, which were consumed previously as considered as low potassium. Now guava is a very rich source of potassium. Like that, you have to follow change, change with time. You have to move to IFCT 2017. And another important thing when it comes to wheat, you definitely need to restrict wheat when it comes to potassium and phosphorus, because it's a major source of both potassium and phosphorus. It's almost 3 times high when compared to rice, and rice can be leached, whereas wheat cannot be leached. And when it comes to preparing chutneys, it becomes difficult to prepare a chutney, especially in South India. So you can take about 25 grams of mint leaves, add it to little bit of onion, little bit of tamarind, ginger, garlic, green chili, whatever, and prepare the chutney, but don't cross 25 grams of mint leaves. Another thing, when it comes to, so many foods which are forbidden foods, they can be included in the diet, provided you do calculations, definitely. See, but one important thing is tamarind is a source of potassium, and also something else. Tamarind is and turmeric is a source of potassium, but you're not going to consume 100 grams of tamarind, 100 grams of turmeric. So if you're going to take it in rationalized quantities, it's not going to trouble your serum potassium value. So be little careful when you're doing the calculations. That is why a 24-hour recall will help tell you that what the patient is consuming and how that, even if it is a source of potassium, how much can be incorporated so that it does not cross the 2000 milligrams, and your daily requirement is 4700 milligrams in a normal adult. But in somebody who's walked into CKD, depending on the serum biochemical values of potassium, you will calculate the diet. Do not follow a blanket prescription. Thank you so much.
Thank you so much, ma'am. We got a lot of knowledge today, and we will surely include that things in our daily practice. Thank you, ma'am. Today I want to thank Mrs. Meenakshi Bajaj, ma'am, and Dr. P. Nazni, ma'am, for their input. We are really very grateful for you. So today we are just finishing our session because we came to the end of the session. And what question we can't attend, we are very sorry, and we will definitely attend the questions and we will mail you as soon as possible. And I want to just thank the convener of IDA Chennai chapter, Mr. Krishnamurthy sir as well. So tomorrow at the same time we will meet here. So tomorrow also we have a session with Mrs. Ikshita Chakrabarti from CMRI, who is the head of the Department of Nutrition and Dietetics in CMRI Hospital from Kolkata. So please stay with us tomorrow at the same time, and you will get in your mail the Zoom ID as well as the YouTube live link. As if you can't join through our Zoom, kindly click the YouTube live link where you can also chat with us directly with live session, and kindly share with feedback, because we share the feedback link as well in our chat box. Kindly share your feedback. If you have any doubt, you can always contact with us. Thank you so much. Thank you, participant, because you are very enthusiastic, and as per your participation only, our program is getting very success. So thank to all of you, all the attendees for the session. Thank you so much.